We respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkwiden, Anishinaabeg, the Three Fires Confederacy, Ojibwe, Odawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. Good evening, everybody, and welcome to the November 3rd, 2022 board meeting. I'm going to call the meeting to order. Do we have any declarations of conflict of interest? Seeing none, thank you. Can I get a motion to approve the previous minutes? We've got Paul Lachance, seconded by Dave Mallion. Thank you. Questions or comments with regards to those minutes? Seeing none, wonderful, thank you. I will give my quick spiel. So as you can see, I have a little stubble on my face. This is day 3 of the Grow on Windsor campaign put on by the Windsor Cancer Center Foundation. So remember, each November, Grow on Windsor raises funds to reduce the need for our brothers, fathers, uncles, and loved ones and friends to travel down the highway for treatment that they should be receiving here. Every dollar raised stays local to support the purchase of vital tools and equipment not otherwise funded by the province. So please go to the Windsor Cancer Center Foundation.org if you're interested in participating or donating. With that, we will go right into the report of the President and CEO, David Mouche. David.
Thank you, Mr. Chair. Share my screen. So welcome, everybody. And unfortunately, I gave it a best try. I put 2 months behind putting together reports in advance for board meetings. And unfortunately, the way things are tracking, November was not that kind to us to be able to prepare something about a week ago that probably will still be valid today. So as a result, myself, Karen Riddell, and Dr. Saad are going to go through the following slide deck and give kind of a snapshot where we are, what's happening locally, regionally, provincially, and also to provide some background about what we're facing and giving some hopefully helpful information to our community regarding the various viruses that are circulating as we speak and that we're concerned about. So this is a consistent, unfortunate story for ourselves, but also across Ontario, across Canada, and pretty much nationally, depending on how many beds you have. But as of 10 a.m. this morning, we were well above 100% capacity at both campuses. What is problematic as a part of this is the fact that we have these patients called admit no beds, A and Bs. And what they are is they are patients who have been admitted in the emergency department, have come to the emergency department, been admitted, but are waiting for an acute care bed, but one is unavailable. So they wait in the emergency department in the various stretchers in the emergency department. As of this morning, this number actually went up a bit as the day went on a little bit, is we had a total of over 37 admit no beds between our new 2 campuses. And just to put that into context, is back in 2019 for the same time period between October 1st and today, back then we averaged 7 admit no beds in the morning, patients waiting for a bed. Now we're averaging close to 30. And of course, that number keeps escalating. I was just on a regional call, and that issue is increasing across the provinces. We're not alone with seeing admit no beds at its highest rate. So right now we have, as I stated, 10 o'clock, we had 37 between the 2 campuses, but that number is actually a little bit higher. At the same time, the one thing we've done very well as a region is our number of alternative level of care. It'd be nice if that was lower, of course, because every single bed is a valuable bed at this moment, but it is low as compared to others across the province. Between our two campuses, it's 34 in total, and probably half of those are waiting for a long-term care bed. So Bill 7, even for ourselves, has created some capacity in Windsor, Essex already. As we proceed, we're hopeful that it will continue to do so, because again, every single bed is a very important bed at this time, especially acute care. So also just give you some stats about patients that are admitted. Now, this is in no way a reflection of what's going on in the community. This is just what we see at our hospital. These numbers are dramatically, of course, higher in the community because they don't have to come to the hospital yet, or hopefully they never have to come to the hospital. So we've had 7 adult patients admitted with influenza, 1 ped patient admitted with influenza. And what Karen and Dr. Sod are going to talk about is RSV, what that means, how one is diagnosed with it, how we might be able to prevent it, and as well COVID. What the concern is, are these 3 viruses are going to start to increase, starting pretty much now. Back 3 months ago, it was projected by the Minister of Health and that it was stated come the start of January, there's going to be 2,400 beds that are needed in excess of what's available, acute care beds across Ontario. And that was when Bill 7 was announced and saying they needed to create capacity, because there was that much, if not more, ALC patients and about 2,500 who were waiting for long-term care. So we needed those beds to be available for acute care patients. Based upon what they're seeing in some tracking of numbers currently, also, again, we talked about this at a previous board meeting, is you look to Australia to see what the influenza season looks like. Influenza season for Australia hit earlier, hit harder, and the admission rates for patients with influenza was higher. So as a result, they've redid some data based upon what we're currently seeing, as well as what was happening in Australia. And we're indicating that we're going to get hit, especially with the influenza RSV, is going to be at its apex during the month of December and not waiting until January. COVID itself, for whatever reason, with respect to their projections, are projecting our worst part of COVID most likely will hit in January still, but our worst part of influenza and RSV will be hitting in the month of December, pretty much right around Christmas time. And that's what's projecting now. And unfortunately, that's what we're seeing across the province. So if you look at, here's a slide that's on a document out of the federal government called Flu Watch. And basically what it shows is this dotted line here is our average since 2014 to 2019 of influenza cases test positive as compared on average for those for that time period for those 5 years. I highlighted the area to see where we sit now, and you'll see technically, and this is 2-week-old data, this goes to the middle of October, we're technically just hitting the average. So one might think, oh, that's okay, we're at the average of the last 5 years. The problem is when we look at this line, most likely in the next when it comes out in about 2 weeks to get us to November, it's always a 2-week lag, that line's probably going to go shooting straight up or on that range as compared to this gradual increase. It's going to happen sooner than what it traditionally does, consistent most likely with what we're seeing in Australia. So you might say, okay, what are we doing to, what do we do to prepare for this? And a lot of this is old messaging, but to reinforce it, we've aggressively over the last 3 years hired frontline clinical staff and have over 400 frontline clinical staff, more than we had in 2019. We have 53 additional acute care beds open. 18 of them are still unfunded. We're still working on that. And as late as this morning, had some calls on that. So hopefully that gets resolved very shortly. And I just pulled from an EMS report that was made public, and it's a good jump off to see where we're at. What we're seeing, and hospitals are seeing this too, is the raw volume of patients coming to the emergency department. The raw volume of patients using EMS is similar now, or possibly even less now, than what it was prior to COVID. We're not even back at pre-COVID, say, emergency room total volumes. The difference is when you peel that layer down, what do you see about those volumes? What is that patient coming in? What is the difference? What's causing this? So one of the things you got to highlight right off the bat is I wish we were doing 100% of the surgery volumes we did in 2019. I wish we were doing 130% of the surgeries we're doing in 2019. We're not. The maximum we're getting is 70. So what that indicates, though, is surgical patients are not sitting in the medicine beds where you can say, well, if you just reduced your surgeries to 100% of the 2019 volumes, you could find those beds. No, we can't. So we're doing as many surgeries as we possibly can based upon available beds. The difference between now and 2019 is back in 2019, we were admitting about 15% of the patients that were coming through the emergency room doors. Now we're admitting 20%. That's 5 patients a day. Not only are we admitting 5% more, but every single one of our patients, on average, close to 600 of them, are staying 2 more days in the hospital than they did in 2019. So what does that mean? That means demand on acute care beds. That wasn't there before. That is there now. Plus a raw number, we're getting about 5 more patients a day being admitted in the hospital on top of it than we had in 2019, even though the raw volumes total is less. This is consistent with EMS. So EMS is going out in the community, picking someone out of the house or somewhere else, at their house or somewhere else. We track their data to say, okay, out of the patients they're bringing in the hospital, are they sicker? Sicker by the basis of, are they being admitted at a higher rate? Sure enough, the number falls between 4 to 6%, on average 5%. So 5% more of the EMS patients being taken now as compared to 2019 are being admitted. So they're seeing sicker patients, which one would assume that when they're on the site addressing the patient's needs and putting them into the EMS take to the hospital, it's going to take most likely longer because they're sicker. They don't track that data, but I think they're going to start tracking it now to see those time elements with respect to their journey if it's increasing. So all in all, that's why we have the issues we're facing right now. And I could pretty much repeat this presentation with different numbers for pretty much every single hospital in the province of Ontario, and I could probably stretch it to all of Canada. Very similar findings with respect to what we're seeing with respect to the patients. Some of the things we've done, this is just an example of 2 things, and there's a magnitude of different things we've done. But starting on October 1st, in our emergency department, the ER physicians really stepped up, and we have one in triage now. I'm at both campuses for those hours, 7 days a week. That's made a significant difference in addressing some of the issues we're facing and getting some of the patients seen earlier than they have in the past. At the same time, back in August, the internal medicine doctors came down to the emergency department and they started seeing patients in the emergency department to help out as outlined there. And that's made a significant difference. And that's happening because they have other jobs outside of the emergency department. That's happening about 50% of the time. But when it does happen, it's making a significant difference to the system. We'll talk about vaccinations in a bit, but this is where I hand it off to Karen and Wasim. Dr. Saad is, this is what they're going to talk about, is you hear about it, RSV, what is that? Influenza, kind of know what that is. COVID, we have an idea, but it's changed a bit. Who do they target, or who do they impact? How can we avoid them? And if we acquire them, what do we do, or what can we do? So I'll pass it over to Karen.
Thanks, David, and good evening, everyone. So we'll start with respiratory syncytial virus, or RSV. So this virus is, I'm fast, but I'm not that fast. So it was actually discovered in 1956, and it's been recognized as one of the most common causes of childhood illness. Causes annual outbreaks of respiratory illnesses in all age groups, typically circulating during the fall, winter, and spring. And the timing and severity of the season varies from year to year, and you're going to see some trends with that as we go through these three different viruses. So scientists are working on developing several vaccines for RSV, monoclonal antibody therapy, as well as antiviral therapies. And it is transmitted when virus droplets from a cough or a sneeze get into your eyes, nose, mouth. You touch a surface with the virus on it, and then touch your face without washing your hands. And it can survive on hard surfaces for hours. You can also get it from direct contact, so like kissing the face of a child can obviously cause direct contact with that virus, or vice versa. And then people infected with RSV are usually contagious for 3 to 8 days, but may be contagious for up to 4 weeks. And children are often exposed to and infected with RSV outside the home, such as in school or in childcare centers. Next slide, please. So high-risk populations with RSV, and we've been talking about this, is premature infants, children that are younger than 2 years of age that have chronic lung or heart conditions, children with weakened immune systems, neuromuscular disorders, especially those that have difficulty swallowing or clearing mucus. And then parents of children that are at high risk for developing severe RSV disease should take that into consideration and avoid close contact with potentially sick people. Wash their hands often with soap and water for at least 20 seconds. Avoid touching their face with unwashed hands, and limit the time that they spend in childcare centers or other potentially contagious settings, especially during those seasons of fall, winter, and spring. Definitely those with chronic lung and heart disease issues, asthma, congestive heart failure, and adults 65 years and over. Next slide, please. So some of the symptoms of RSV, and you're going to see a trend with this as well, is rhinorrhea or runny nose, a decrease in appetite, a cough that usually develops a couple of days into the illness, and soon after that cough, sneezing, fever, and wheezing may occur. In very young infants, you might see irritability, a decrease in activity, and or apnea, which is stopping breathing for periods of time. Those may be the only symptoms that they demonstrate. They might not have that coughing and sneezing that you see with older children. Most adults that get RSV usually have mild or no symptoms. They might have a runny nose, sore throat, cough, headache, fatigue, or fever. And older adults 65 and over, and especially those with chronic lung or heart disease and weakened immune systems, may experience lower respiratory tract infections such as pneumonia. Next slide. So for treatment for RSV, most RSV infections do go away on their own in a week or two, and there is no specific treatment for RSV. Some children may require hospitalization for hydration and airway support, and some may even require mechanical ventilation to support them. Typical symptom management is for fever and pain, over-the-counter fever reducers and pain relievers. And just a reminder, never give aspirin to children. Drinking enough fluids, it's very important for those with RSV infection to maintain their fluid intake and avoid dehydration due to loss of body fluids. And make sure that you do talk to your healthcare provider before giving your child any non-prescription cold medicines. Some of those medicines that are sold over the counter are not good for children. And definitely call your healthcare professional if you're, I need to get that last line. If you or your child are experiencing signs of serious illness, such as difficulty breathing, not drinking enough fluids, and experiencing worsening symptoms as above. So there is prophylaxis available for some high-risk infants. And the ministry does cover the cost of the drug that is used to prevent severe lower respiratory tract infections in infants less than 2 years of age and high risk for disease. Those are infants that have prematurity, Down syndrome, or trisomy 21, lung disease requiring oxygen or medical therapy, congenital heart disease, congestive heart failure, and others that might be at high risk of hospitalization and complications from RSV. So we actually run a clinic for this prophylaxis out of the hospital for our high-risk infants in the community. And I'll hand it over to Dr. Sad now to talk a bit about influenza.
Thank you, Karen. Good evening, everyone. So what is influenza? Whenever you hear the term flu, that's usually what people are referring to, although, when you hear about flu, it could be a common cold, which is a variety of other viruses, versus influenza, which is a very contagious respiratory illness. It can cause anywhere from mild to severe illness, and that sometimes can lead to death. The flu virus does typically circulate in the fall and winter, and that's what we usually call the flu season. And again, depending on what hemisphere you're in, the winter season may be different. And this is why we sometimes track what happens in the southern hemisphere, because their flu season and their winter oftentimes mirrors what ends up happening in the northern hemispheres. Typically, for us in the northern hemisphere, it does begin and start to increase in October, November, and then will sometimes peak December, early January. But you can develop and acquire influenza throughout the year. Since the start of the COVID pandemic, the timing and duration of the flu has been less predictable, partly because of all the public health measures that we have in place. And I've reported to this board in the past about an influenza season in the southern hemisphere that was 0. And it mirrored here in the northern hemisphere when we're across all of Canada, we had no more than 50 cases of influenza, which is unheard of. So it can fluctuate up and down. The highest risk populations for influenza are those that are at the extremes of age, usually young children less than 6 months of age, those that are 65 years or older, and then those that are in between usually have to have other types of risk factors. Healthcare workers, because of the heavy exposure from their day-to-day contact with a sick population, those with chronic conditions, usually heart, lung disease, asthma, diabetes, and pregnant women are always at higher risk for any type of infection just because of the compromised immunity. So the symptoms of influenza are very similar to what Karen described with RSV, and are going to be very similar to what we're going to be describing with COVID, which is why it's almost indistinguishable. If you start to develop a cough, a sore throat, a runny nose, you're feeling tired, you cannot tell, and your healthcare provider cannot tell whether it's influenza or COVID as an adult, and if you're a child, whether RSV is in there as well. You oftentimes do have to do testing. So you'll notice that the symptom list here for influenza is almost the same as it is for RSV, and is the same as what it would be for COVID. With influenza, most people will recover in a few days and typically will not last longer than 2 weeks. If it does last longer than 2 weeks, you have to start thinking that there could be something else in it. And in those patients who are at the extremes of age or have risk factors, there is an increased risk of concurrent sepsis, pneumonia, inflammation of the heart, and it can be lethal in some cases. What to watch out for as an emergency are, difficulty breathing beyond, climbing a flight of stairs and feeling short of breath. If you feel like you're at rest and you're having trouble taking a deep breath in, or you notice a child breathing very heavily and very quickly, that could be a sign. Cyanosis, which is a medical term for lack of oxygen in the blood, will present as a blue face or blue lips, and that's another reason. Extreme fevers that you're not able to get down with Tylenol. It can also be a reason to present for medical care. And dehydration, as always with any illness, if you can't keep up with your fluids and need to have an intravenous, that's another reason to come to medical attention. Bottom line is, most patients and family members will recognize when things are getting worse. After an infection, there's always a type of peak, and then things will start to improve. And if that improvement doesn't happen, most people know better and will seek medical attention. But that's a non-inclusive list of things to watch out for. that would prompt you to come to the emergency room. And again, similar things for adults as it is with children. So we can move on to the next slide. There are limited treatments for influenza. There are some antiviral drugs. The one that people are probably most commonly familiar with is Tamiflu. It's a pill that you take shortly after acquiring influenza infection. It's not for everybody. Again, young, healthy people who acquire influenza oftentimes don't even know it's the flu and recover on their own. But if you happen to be tested and you're high risk and it's a known influenza, you can be given an oral course of Tamiflu to try to mitigate the duration of the illness and some of the severity of the illness. But it is not for everybody, and most people wouldn't even qualify to be treated with it. Next slide, please. And I'll hand it back over to Karen to start the discussion for COVID.
All right, so we've heard a lot about COVID over the last couple of years, but just as a reminder, so coronavirus disease or COVID-19 is an infectious disease caused by the SARS-CoV-2 virus. And again, similar to RSV and influenza, most people do experience a mild to moderate respiratory illness and recover without requiring special treatment, but some do become seriously ill and require medical attention. So older people and those with underlying medical conditions, just like with influenza and RSV, like cardiovascular disease, diabetes, chronic respiratory disease, and cancers, are more likely to develop serious illness. But we do have to remember that anybody can get sick with COVID-19 and become seriously ill or die at any age. It does spread from an infected person to others through respiratory droplets and aerosols that can vary in size. And it can also be spread just like RSV and influenza by touching something that has a virus on it and then touching your mouth, nose, or eyes with unwashed hands. Next slide. So high-risk populations, again, are similar as well with influenza. So older adults, and each increasing decade increases risk. Those that are pregnant, have Down syndrome, have not received all of their COVID-19 vaccine doses, have a chronic medical condition, are immune compromised, or live with obesity, in particular if your BMI is greater than 40. Next slide. So symptoms do vary from person to person in different age groups. They also depend on the COVID-19 variant. So we've seen a lot of differences in presentations over the last couple of years. So it can vary between sore throat, runny nose, sneezing, cough, shortness of breath, fever, fatigue, weakness, muscle or body aches. One thing that was unique to COVID that we don't typically see with the other infections is a loss of smell or taste, headache, and some GI symptoms and feeling unwell. But you can see, as Dr. Sad mentioned, you can't tell from your symptoms if you have COVID-19 or the flu or RSV, and we really do need testing to differentiate that. Next slide, please. So like we said, symptoms do vary, and they can start anywhere from 1 to 14 days after exposure, and you can still spread the virus if you don't have symptoms, and we've talked a lot about that. It's important if you do develop severe symptoms such as trouble breathing, severe shortness of breath, persistent pain or pressure in the chest, confusion, difficulty waking or staying up, and again, the cyanosis symptoms, so showing that you're not oxygenating well, so pale, gray, or blue colored skin, lips, or nail beds. Next slide, please. And then I'll turn it back over to Dr. Sad for the prevention and treatment.
Thank you, Karen. So what's unique with COVID-19 is we have vaccines that are more effective than influenza vaccines. When the influenza vaccine comes out, it's usually modeled after what's happening in another part of the world, usually in China. They try to predict what variant or what mutation is arising that year. And then the estimates in previous years is anywhere from 40 to 60% in terms of efficacy. Thankfully, with the COVID-19 vaccines, we know that although they do not necessarily prevent you from acquiring the infection, so they're not what we call sterilizing vaccines, they do play an important role in preventing severe illness and keeping you out of the ICU and out of hospital. There is absolutely no question about that anymore. It's been validated across multiple studies, and prevention is critical in terms of getting vaccinated, maintaining a booster schedule to ensure that you maintain that high level of antibodies to prevent death and ICU admissions. We do have different types of treatment for COVID-19, from outpatient oral treatments like Paxlovid to inpatient intravenous treatments and steroids if you happen to be in hospital requiring oxygen or in an ICU. There are various different treatments that have been developed that have been shown to be effective against COVID-19 and severe infection. So influenza and COVID, so we know that they're both contagious and they're both caused by two different viruses, two different families of viruses. COVID-19 does seem to be spreading a little bit more easily than flu. There are vaccines for both, but as I mentioned, some are more effective depending on what year for influenza. But COVID-19 we know is extremely effective at reducing severe illness and death. You will sometimes hear the argument that COVID is no worse than flu, and that is not true. COVID-19 is more severe than flu, and it is more lethal and deadly than influenza. COVID-19 kills more people than influenza. People who are infected with COVID-19 may take longer to show symptoms, but are usually more contagious. They can actually be contagious for almost 10 to 14 days, whereas with COVID-19, again, depending on your vaccination status, it could be as short as 5 to 7 days. And that sort of informs some of the public health measures that we have that tell people they can, leave the house and don't necessarily have to be masked after 5 days. And people with flu and COVID at the same time can have more severe disease than if you had one alone. And this is part of the reason why we're anticipating a worse season now, because we're expecting a confluence of influenza, COVID-19, and RSV, which is likely to lead to more hospital admissions. And we're already starting to see some of that in the pediatric population, particularly with RSV season. So it is possible to be infected with multiple viruses at the same time. So the recommendations, obviously, is to take every preventative action that you can to prevent them. Get vaccinated for those that have vaccines like influenza and COVID-19. If you are sick, the recommendation is always do not go out and expose yourself to other people. You're likely to contaminate someone else. Limit contact as much as possible. Standard things like cover your mouth and nose when you cough, wash your hands with alcohol rubs or soap and water, and avoid touching your eyes and other mucous membranes where the virus can interact, and disinfecting surfaces, as Karen mentioned. Particularly with RSV, it can remain on hard surfaces for many hours and sometimes days. I think there might be one more slide. So I don't know how well this is presenting, but we sort of went over some of these numbers earlier. The slide on your left is for both influenza A and B, and the slide on your right is for COVID-19, and just basically shows surveillance week over week for the past year. So it goes all the way back from October of 2021 into 2022. You'll all notice the spike last year and near December for both. Then things started to settle down, and we started to see an early and high spike in influenza this year. But COVID is sort of grumbling along. But this is what we're worried about: is the spike in COVID that is likely to come and coincide with influenza at the same time. I think that's all our slides. And we're happy to take any questions if anyone has them.
Great. Thanks, Dr. Sad. Any questions for David, Dr. Sad, or Karen? Or seeing none, no, that's a great synopsis on all three items that are affecting our community right now. David?
Yeah, if I could just add before we close, typical to almost every single trend we see, the way things happen, we talked about the Southern Hemisphere and we replicated here. We talk about what's going on in the UK, especially during COVID. It just looked like it went across. And then it starts in Ottawa, works its way through the GTA, Kitchener-Waterloo, then comes down to Windsor. Sure enough, the exact same thing's happening with what we're seeing with RSV and influenza is along that same track. And I just saw some data today that after about a 6-week period, the UK is starting to drop now with respect to some other issues with respect to COVID, especially. It's dropping a bit. So it's a 6-week period that we're going to be facing that we're probably going to be starting in a little bit ourselves. And as stated, through November and December and at the start of January. And then unfortunately, they say COVID's going to hit us a little bit later. So we already saw one patient under the age of 1 that came in with all 3, RSV, influenza, and COVID. The patient has been addressed clinically and has been discharged. So that's positive news there. So it does exist. It does happen. You know, what Dr. Saad and Karen outlined are some preventative measures we can do. One portion of slide I did not include is a comment just a couple of days ago by the Chief Medical Officer of Health of Ontario, who indicated without saying it directly, but saying that he continually looks at the use of masks and possibly the reimplementation of such. And it's going to be most likely determined if our influenza rates continue at a rate of subsequent weeks of 5% increases, then we are in trouble. And unfortunately, there's probably no indication at this time that it won't increase at that level, as I stated before, where that line for influenza is probably going to jump up pretty high. So based upon that, that's our report. And again, the goal here is not to, get people overly concerned, because then some people say, the sky's falling. But there are certain things we can do individually and collectively that can reduce this and try to keep it down as best as we can. And we all have an obligation to do that for ourselves and our loved ones, especially, we're going to start hitting the holiday season, et cetera. So just keep all of this in mind as information, but also recognizing that the months of November, December, and January in the hospitals across Ontario, including ourselves in Canada, it's going to be very strained as they are now. Thank you.
Thanks, David. With that, any questions or comments? Seeing none, we will keep moving on. The Schulich report is there for your information. Unfortunately, Dr. Jacobs could not be with us tonight, so we'll move on to the financial presentation with Ian McLeod.
Matt, if you could put the presentation up, please. Good evening, all. Matt, the first slide, please. We have a funding update for this month. The surgical recovery premium will be available again this fiscal year. Similar to 2021 and 2022, the premium is set at 15% of the current funded rate for each surgery applied to the last 25% of the volume allocation. And we'll get an accountant into the room to explain that, but that's the way the formula works. Based on our surgery recovery plan submitted, our estimated potential additional revenue is $1.8 million, which is actually very good news for us. Next slide, please. The financial results for the year-to-date September 2022, we have a $2.4 million deficit from hospital operations, which is $210,000 worse than planned. The net deficit after building amortization is $2.9 million, which is $161,000 better than planned. Next slide, please. This slide shows the breakdown of the $13 million in COVID-19 expenses. Unfunded COVID-19 expenses total $2.9 million, actually almost $3 million, due to the wage differential for the nursing externs, Expenses no longer funded via the incremental expense reimbursement which occurred after June 30th, 2022. Includes sick and isolation costs and additional staffing in the perioperative program, incremental PPE, additional shuttle cost, and storage of equipment. We expect the $262,000 gap in medical remuneration to be fully funded. Revenue shortfalls in the three categories are not funded. Volume based for quality-based procedures, neuro, cardiac, and wait time. When compared to the budgeted volumes, there is a $5.6 million shortfall. $1.4 million revenue loss in patient services revenue, and $402,000 revenue loss in other recoveries. Next slide, Matt, please. Salaries and benefits have a $3.8 million deficit. This includes the $3.2 million temporary retention incentive for nurses, payment of which was now fully funded. Also $5.6 million in funded expenses for nursing externs and COVID-19 incremental cost. Medical staff fees of $4.4 million deficit. $2.8 million is funded through the COVID temporary physician funding. $2.88 million offsetting favorable patient services variance, revenue variance. Medical and surgical supplies show a $735,000 deficit. 91% of this deficit relates to the incremental PPE that has been used. Drugs are $482,000 in a deficit position, which is offset by favorable revenue in retail pharmacies. Next slide, please. Significant variances include other supplies of $1.7 million deficit. That includes $963,000 in legal fees, $718,000 in building grounds maintenance and service contracts, $250,000 for referred out patient transport, and $226,000 for physician recruitment. The deficits above are offset by some favorable variance, being $402,000 in equipment and software maintenance, $215,000 in printing supplies, and $130,000 in staff travel. That concludes my report, Mr. Chair. I would make a motion that the November 3rd financial presentation for the results as at September 30th, 2002 be accepted, and take any questions.
Thanks, Ian. Can I get a seconder, Penny Allen? Thank you. Questions, comments, concerns with regards to the report? Seeing none, all in favor? Perfect. Thank you, everyone. With that, we have correspondence and printed material there. In tab D. Oh, actually, sorry, I think we made the motion to accept your report. Okay, yeah, sorry. We have our consent agenda as well. Ian, are you motion to accept the consent agenda? I think I doubled up. Did I? Yes. Okay. Everybody's nodding. Okay, correspondence, printed material are there for your information. Questions or comments from any of the board members? Seeing none, I forgot to mention two things. Number one, I want to wish a big congratulations to Julie Lane. She had 6 medals in the World Down Syndrome Games. Her mom is in the IT department with Transform, one of our partnered organizations. So congratulations, Julie. Fabulous job representing Windsor-Essex County in Portugal. And then secondly, big congratulations to Christina Nacarado. So after an extensive search, the Windsor Regional Hospital Foundation was pleased to announce that Christina as the successful candidate for the position of Executive Director of the Windsor Regional Hospital Foundation. So many of you may not know her yet. She came to Windsor Regional Hospital in 2019, and then obviously COVID. So you may not have had the chance to meet her yet, but exceptional individual, and looking forward to her leading the charge in the coming year. So congratulations to Christina. With that, the date of our next meeting is off by a little bit. So it's actually going to be Thursday, December the 8th at 5 p.m. Again, that's December the 8th. So it's not the first Thursday of the month. It's actually the second. Can I get a motion to adjourn? Linda, seconded by Genevieve. Thank you. Questions, comments, concerns? Seeing none, all in favor? Wonderful. Thank you, everybody. For the board members, why don't we take 5 minutes and then we'll come back for the open session. So let's say 5:55. Perfect. All right. Thanks, everybody. Have a good night.